All right, good morning, everybody. Thanks to Karthik for having me give this talk. I'm going to go over angioplasty for unprotected left main stenosis, just a little outline of what I hope to cover. A lot of what I'm going to say, people probably already know, but I think it's important to kind of put the talk in perspective by kind of reviewing experience. And a little bit about PCI cabbage, although I think that's kind of a little bit uninteresting these days. We've been there and kind of gone over that pretty well. I'm going to spend most of the time talking about technical considerations about how we should do it, and then finish up with a little bit about patient selection. So just remember, it's fairly common. Severe left main disease angiographically is only about 4 or 5% of what we see. But if you take a broader view of left main disease, so what we would describe as moderate or insignificant or not severe left main disease, by a visual estimate, 25 to 60% say, and you IVUS all of those, fully half of them will have severe stenosis by IVUS area. And so the angiogram, for all the reasons we know, is a poor measure of the severity of left main disease. So certainly left main disease is very common. We know that medically treated left main stenosis does not go well. The mortality can be as high as 36%. You know, that's fairly old data, but probably still is true even with today's optimal medical therapy. And as recently as 2008, angioplasty of unprotected left main was fairly uncommon, at least in this country, with only about less than 5% of people with left main disease getting angioplasty and stenting. So just a quick review of the surgical data. This is from the CAS registry, 25,000 patients, 1,500 of whom had left main stenosis. This is in the 1970s, and it's bypass surgery versus medical therapy at that time. But you can see that the curves diverge early and stay separated over 15 years of follow-up. So certainly bypass surgery very early on was established as the standard of care. Now, Dr. Grunzig observed very early on that left main stenosis should be relatively ideal for PCI. It's proximal, so that it's very easy to access from your guiding catheter. In general, it's a short segment of disease because the distance of most left mains is short. And it's the largest segment of the coronary tree, so that the final diameter should be sufficient. And in fact, Grunzig's third patient, which he reported in this paper in Lancet, had severe left main stenosis, and he reported the procedural success several weeks after, but subsequently the patient died suddenly at 6 months. And Grunzig noted that perhaps restenosis, silent restenosis, was the culprit, and kind of backed away from the idea that angioplasty for left main disease was a good idea. This is the first series of left main angioplasty reported from Jeff Hartzler's group at what is now Mid-America Heart Institute. And the majority of these patients in this series, it was elective, it was not urgent or in the setting of STEMI, but they had real reasons that they couldn't have bypass surgery. And even in this elective series, the mortality at 48 months was 65%. So the early experience with left main angioplasty was particularly gruesome. And for at least my generation of interventionalists, everybody who had left main disease was kind of shunted toward surgical treatment. But that has changed in the last 15 to 20 years as we've gone through several cycles of technology and stent upgrades and a lot of learning about how to do this. And the mortality has come way down now into the low single digits for the most recent randomized studies. So I think that's an important look back and an important realization that we've come a long way and learned a lot. And I think it's important to review what we've learned and why. This is NCDR data that Dawn Abbott published a few years ago that shows that still, relatively speaking, unprotected left main angioplasty is fairly uncommon. Less than 2% of all angioplasties in this country, but the numbers are rising. The absolute numbers of angioplasty of the left main is rising. And so I think people are becoming increasingly comfortable with this lesion subset. And certainly our experience here is that many times it's out of necessity for patients with an increasing number of comorbidities who are not surgical candidates. Just a few words about angioplasty versus bypass surgery. Certainly angioplasty versus bypass surgery is a very old question. In this lesion subset, though, I think the data is pretty settled. This is a meta-analysis that our own Dr. Ahmad published 18 months ago or so, kind of looking at the 5 trials, randomized trials of angioplasty and bypass surgery for people with left main disease. And the bottom line is you can see that it's equipoise. If you have a patient who is an equally good candidate for bypass surgery and angioplasty that both the surgeons and the interventionists agree could be treated successfully, then either option will give you the same result in terms of overall mortality. This is, I think, Yusuf can correct me, but I think that the average follow-up in this was about 66 or 67 months. But obviously not every patient is equally suitable for bypass surgery or angioplasty. There's a number of factors that we recognize that will shift the equation one way or the other: diabetes, low ejection fraction, and inability to take antiplatelet therapy certainly would, in general, favor bypass surgery. There's a large question about whether a right coronary CTO or a left dominant circulation should shift the equation toward bypass surgery instead of angioplasty. I think it's still unsettled in terms of the available data. But certainly other comorbid conditions that would increase surgical risks, such as prior stroke or severe lung disease, severe peripheral vascular disease, and general frailty, kind of shift the equation towards PCI. I think one thing to keep in mind as you look at this option of bypass surgery and angioplasty is that in every trial comparing angioplasty to bypass surgery, there's always an excess of revascularizations or repeat revascularizations in those patients who are randomized to PCI. This is Kaplan-Meier curves from the Barry trial, one of the first studies that randomized patients to either bypass surgery or angioplasty. And you can see that, oops, sorry about that, in this upper left panel, there's my pointer, that the first subsequent revascularization, either another angioplasty or bypass surgery, occurred with much more frequency and continued to occur with more frequency in the angioplasty group. This is pre-stenting, so that within the first 3 to 6 months, there was a big jump here as patients presented with restenosis. And So it doesn't matter if they had surgery or repeat angioplasty, the frequency of that was almost 60% by 5 years. Fast forward to the Excel trial, now the numbers are a little different. 7.6% in patients who had bypass surgery had another revascularization, and only 13% in the angioplasty arm, but still a significant proportion and associated with increases in both all-cause and cardiovascular mortality. So when you're looking at PCI versus CABG, the numbers are that you're more likely to come back for another revascularization if you have angioplasty as your initial treatment strategy. And so we want to make sure that we're choosing patients who we think we can get a good result on and really minimize their risk for subsequent revascularization, because it does have serious implications for overall mortality. So now I'd like to spend most of the remaining time just talking about technical considerations. If we choose to do left main angioplasty, what are the things that we need to think about, and how can we get our best result? So this is a little bit corny, but to make the point that there is a huge amount of data now that we can draw on to kind of inform ourselves about how best to do this. Whether you look at specific trials of left main angioplasty or other surgery bypass trials, or other trials of to left main PCI so that we can get our best result. So what have we learned over this period of time with all these trials? The key thing is to plan. So left main angioplasty, in my opinion, is not something to take on immediately after a diagnostic procedure. I think in almost all circumstances, it's appropriate to stop, review the diagnostic films, make sure you understand everything about the lesion and other disease so that you can meet with the patient and speak with a surgeon and have a completely informed discussion before proceeding, making sure you understand what the downsides of potential angioplasty are. And it's not just the films. You have to kind of take the entire patient, obviously, into consideration, understand what access sites are available to you, both primary and secondary, especially if you were to need some kind of mechanical support. You want to think carefully about your guide selection, how much backup support you'll need. Think carefully about LV function and how that affects your plan to do angioplasty or to recommend surgery. And also sedation difficulties. Many of our patients who need left main angioplasty have other comorbidities and advanced age, which will complicate their ability to lay still through what can be a long procedure. And finally, I think it's probably safest to do these procedures in those patients who have had 12 to 24 hours to receive a loading dose of antiplatelets and make sure that they're protected with antiplatelet therapy as best as possible. What else have we learned? Imaging is crucial. And by imaging, I think either IVUS or OCT is acceptable. Certainly, there's much more experience with IVUS. And because left main PCI often involves the left coronary ostium, that can be an area that's difficult to image by OCT, but certainly you can use OCT. But ancillary imaging is absolutely crucial to successful left main PCI. And you need to do IVUS early and often. So before you do anything except in those lesions that are extremely severe. A pre-procedural IVUS is key to understand the extent of plaque in both the LAD and the circumflex, the distal reference in that artery that you're going to declare as the main branch, which is most often the LAD. You want to make sure you understand the landing zone in the left main proximally so that you can choose your post-stent expansion balloons appropriately. You want to make sure you understand any calcification and need for plaque modification, and look for trouble at the bifurcation to make sure that you plan your procedure and the technique you're going to use appropriately. Once you place a stent, then again, you need to repeat IVUS to make sure you have adequate stent expansion, that you've covered everything that you need to cover, to make sure you look for any complications, and to make sure that you've created a new satisfactory bifurcation. So ancillary imaging is not just once, but you need to repeat it many times during the procedure to make sure you're proceeding along a successful strategy. This is kind of a well-known illustration from S.J. Park's group in South Korea, which shows the areas which are associated with the least repeat restenosis in patients who are treated with unprotected left main PCI. So the left main area is 8. The point of confluence area 7, proximal LAD or LAD ostium at 6, and the circumflex ostium at 5. Certainly these are kind of minimal objectives. Going bigger would certainly be better, but you can kind of use these areas. They're easy to remember because they line up, and because it's kind of a benchmark for you to get to as you do your procedure, your post-dilatation, and your IVUS. Importantly, using IVUS is associated with improved outcomes in left main PCI, and I kind of have these 3 references up here. If you look at any of the important outcomes that we value in PCI, stent thrombosis, target vessel revascularization, target lesion revascularization, and mortality, all of these are improved with the routine use of IVUS. So this is a hard outcome. The mortality is not something that is an outlier in any of these studies. There's a number of studies from a number of countries that have come up with the same conclusion, that those operators that do left main PCI using intravascular imaging really impact long-term mortality. So I think it's key. This is not just someone like myself who loves to do intravascular imaging. This is a really important and necessary piece of what we do because it impacts survival. The next question is really how best to tackle a distal left main bifurcation lesion, 1 stent or 2. And there's an awful lot of data to sift through, and I don't mean to take up too much time going through all of it, but I do think there's some key concepts to understand. The first concept is that, crossover from the left main into the LAD, a single stent strategy, provisional strategy, all those terms apply to the same thing in general with any bifurcation in the coronaries, but additionally in the left main, that is in general going to give you your best outcome. And the key steps to this are to make sure that you size your distal stent to your landing zone in the LAD. Make sure you have enough stent in the LAD that you can use a short balloon, an 8mm or 12mm balloon in the distal left main to optimize this point of confluence and kind of get the appropriate stent strut interface with the circumflex ostium. So this is a straightforward procedure. It kind of leaves you the option of stenting the circumflex if there's compromise that you don't expect. But by and large, this is the preferred strategy to do left main PCI. And the crossover can go from left main to LAD, which is the case in this patient. You can see by both the angiogram, and then we also saw by IVUS that the left main, that the circumflex ostium was not affected. Or you can go left main into the circumflex, as was in this case, where IVUS of the LAD surprisingly showed very little disease in the prox LAD and at the ostium. And so this situation, left main into LAD, is much more common, but it is about, the estimates are about 5% or 6% of left main angioplasty will be best served by crossover into the circumflex. And both of these had good angiographic and IVUS outcomes and clinical outcomes. And either way you do it, you can get a satisfactory result in the left main. What about a dedicated 2-stent strategy? This is data from the COBIS registry, which I'm pretty certain is South Korean bifurcation registry, looking at 1 stent versus 2 stents in the left main. And you can see in those patients treated with 2 stents, the outcomes were worse, whether you look at mortality, myocardial infarction, stent thrombosis, TLR, or target vessel failure. And certainly data like that gives you some pause about using 2 stents in the left main. But from the same data set, you see that these patients were older, had more multivessel disease, had a higher syntax score. A higher proportion of them had very high syntax scores, over 33. And the final diameter achieved in the distal left main was less, arguing to more extensive disease, both in the left main and in the remainder of coronaries. So very often, 2 stents strategy is by necessity because of more severe and extensive coronary disease. And I think that's what, by and large, drives a lot of the worst outcomes, obviously, when you're forced to use 2 stents. So I just want to highlight 2 studies here that kind of addressed this question head on. The DK Crush 5, published in 2017. We've certainly gone over this trial a lot in this Wednesday conference. In this trial, complex disease was identified through these parameters. And so whether you look at complex lesions, any 2 of these factors, or simple lesions, a 2-stent strategy using the DK Crush technique was superior to the provisional strategy. However, just last year, a very similarly designed study, EBC Main, which had about the same number of patients, came up with a different conclusion. In this case, a dedicated 2-stent strategy had more events, did not achieve statistical significance in this study for either the primary endpoint or the secondary endpoints, but it was certainly a neutral study that said that it was not better than a provisional strategy where it was a single stent and then only treating with a second stent as necessary. So 2 big studies, 2 contemporary studies that came up with kind of opposite conclusions. So the definition registry set out to understand what should be identified as complex bifurcation disease. I'm pretty sure this is a group in China who had an initial cohort where they looked for those factors that predicted poor outcomes and those factors that would be best served by 2 stents. And then they had a validation cohort. And they came up with only two criteria: a side branch stenosis greater than 70% and side branch disease longer than 10 millimeters. And it turns out if you use the definition complexity parameters, DK Crush 5 mostly met the complex definition as defined in this study, and EBC main did not meet the complex bifurcation criteria by and large. And here you can see this in this table, shows the number of patients. The syntax score is higher in the DK Crush. The lesion length in the side branch met the complex definition of greater than 10 millimeters in DK Crush, but it was less than 10 millimeters in EBC main. And IVUS use was a little higher in DK Crush and less in EBC main, but certainly surprisingly in the minority. So I think these two studies are complementary in a way. If you use this definition of complex left main disease and restrict it to these two criteria, then this is a study that had mostly complex left main disease and showed a benefit with a two-stent strategy. This is a study that had mostly not met this definition of complex left main disease and showed that provisional strategy was adequate. So I think our two largest and most contemporary studies randomizing to either provisional or two-stent strategy come up with the same conclusion, that the most complex disease by this definition would stand to benefit most from the two-stent strategy. The European Bifurcation Club routinely puts out consensus documents. Actually, the 13th consensus document, which was just published a few months ago, I'm pretty sure. And so I don't have the most updated recommendations. But their recommendations in 2018 also included recommendations to use a two-stent strategy if, for example, it's left dominant circumflex, if the angle off the left main of the circumflex would make reaccessing the circumflex very difficult, or if your pre-procedural IVUS gives you some indication that the circumflex would likely be compromised above and beyond the criteria on angiography. So I think if you kind of restrict yourself to these requirements, then you can easily identify those patients who would do best with a upfront two-stent strategy. Which two-stent strategy should you use? This is an example of the two-stent strategies used in the Excel trial. T-stenting was most common, culotte was next most common, a crush strategy was third, and then V-stent and simultaneous kissing stents were kind of minority. I don't even know what other strategies there are beyond these, but the other was 3%. These two strategies are kind of no longer in vogue. Very rarely would you use them. So I think I'm not going to discuss those, but I would like to go through the remaining techniques and just see how they apply in this lesion subset. So these are the three strategies that I think people most commonly use: DK Crush, culotte, and a T-stenting. Just to remind everybody that the DK Crush crushes the first stent. You have a little bit of triple layering here, and the second stent is in the main vessel and recreates a new carina. Culotte is two stents overlapped at the distal end just before the bifurcation, which gives you a lot of metal, for example, in the distal left main. And then T-stenting, you place your primary stent and then subsequently place the side branch stent afterwards to create this kind of neo-carina here in the proximal LAD. So looking at culotte, DK Crush 3 kind of answered the question there. This is a direct comparison between DK Crush technique and culotte stenting in left main disease. And so, whether you look at overall MACE or target lesion revascularization, DK Crush was superior to the culotte technique. Stent thrombosis was low and kind of minimally different in both techniques. And similarly, myocardial infarction was pretty low. And I don't think this achieved statistical significance. I guess it did, p.035. So a large number of patients, 415, but I think the conclusion is fair. Culotte stenting is probably not the best strategy for distal left main. In the COBIS registry, one of the indicators of not achieving a good area in the distal left main was use of the culotte technique, where you have so much metal right at the bifurcation. So that's culotte. I think in the remaining two strategies, but even in culotte 2, I think if you're going to use that, the key is really attention to detail. Each step needs to be done and done carefully and correctly. And so you need to understand what you have to do to kind of get the best result, and then experience is key. So whatever you feel most comfortable with, whatever of these strategies you feel you understand the best, certainly that's the strategy that you should choose. In all of these, there are several key steps: proximal optimization, imaging, and then I'll just show a little data on a final kissing balloon. So remember, proximal optimization is meant to kind of deal with this size discrepancy. If you do single stent crossover and you choose the stent size based on your landing zone in the LAD, that means that your stent in the left main is going to be undersized, which is fine. The key is to make sure that you land in the right zone here, you don't cause distal dissection, and then you land enough stent in the left main so that you can bring a short balloon in and expand this left main part of the stent. And this is why pre-procedural or pre-stenting IVUS is so key. You need to know this dimension because you need to know what balloon to take after you place the stent. And you need to know the size here so that you can choose the right stent size so that you don't run the risk of causing difficulty distal here. Once you've placed your stent, then you can take a short balloon, an 8mm balloon or a 12mm balloon. You bring it right to the ostium. It shouldn't extend into the ostium of the LAD, but right to the ostium. And you want to make sure that you really expand it to force this stent down across the circumflex ostium. And in this series from Europe, routine use of POT was associated with decreased stent thrombosis and decreased target lesion failure. All comers bifurcation. This is not a left main data set, but I think there is data. Certainly, it's now really part of I always say there's science and there's religion in angioplasty. I think this has moved from religion to science, and I think we all believe that it's a critical component of doing good bifurcation angioplasty, but especially left main angioplasty. Final kissing balloon, there's certainly a lot of studies out there addressing this question. And let me just summarize by saying that if you use a single stent in the left main or other bifurcations, final kissing balloon angioplasty is associated with neither harm nor benefit. And there's two pretty large studies that look specifically at left main disease and the use of randomized use of final kissing balloon angioplasty. So if you're going to use a single stent technique, you get a great result. The circumflex is not compromised. You shouldn't feel compelled to recross and dilate into the circumflex. The exact opposite is true if you use a two-stent technique. Certainly some two-stent techniques like DK crush mandated as part of the procedure, but any two-stent strategy in the left main, you need to use non-compliant balloons size 1:1 with the distal reference in that branch and the shortest proximal overlap has the best results. I'll just show you one data slide. So this is a little bit complicated, but if you look first here on the left panel, this is for two stents. You can see that final kissing inflation, lower TVR, lower TLR, lower stent thrombosis. Mortality was not different statistically, and overall MACE was less when you used final kissing inflation in any two-stent strategy. So this is a registry. This is not randomized data. When you look at the overall population, the shortest overlap was associated with the best results, especially with regard to TVR and TLR. So I think the general recommendations are that if you use two stents, you absolutely need to do a final kissing balloon inflation. You want to size them 1:1 for each branch, and then have a very short overlap in the distal left main. Okay, so we talked about planning, we talked about imaging, we reviewed technical details of the stenting techniques available, and then just a few comments on other factors. Remember that stents and thinner struts have continually improved our outcomes in all aspects of angioplasty, and that's certainly the case in left main stenting as well. So in our environment here, we are using very thin struts, either the Synergy or Science or Onyx. The Orserio is also out there, not available yet at Yale, but even thinner struts. And so certainly it goes without saying you're going to use thin strut stents. They are associated with, the lower you go in terms of strut thickness, the lower the stent thrombosis and MI is. So that's an important consideration to think about. It's certainly the direction that we're moving in angioplasty generally, but also important to keep in mind in this left main subset. The other important thing is operator volume. This is clinical outcomes adjusted for quartiles of operator volume. And this is from the UK. You can see that the highest volume operators had the lowest in-hospital MACE, in-hospital mortality, and 12-month mortality. So experience matters. And I think, the more experience you can get and the more of these you can do, I think you need to kind of make sure that we work together and everybody learns how to do it and do it right and gets lots of experience, because certainly that would be important in terms of best outcomes for our patients. There's also a interaction between operator volume and institutional volume. This is a registry of all angioplasty, but that interaction certainly is operative in left main angioplasty. And institutionally, I think we have a very good volume of left main PCI here, a very good experience. And so we should be in this group where we have experienced operators and experienced institution, and we can offer this to our patients with good confidence for good results. So a number of factors are going to influence unprotected left main angioplasty outcomes, operators, institutions, and kind of very careful attention to detail in terms of how you proceed through the angioplasty procedure, what strategy you're going to use, whether it's one stent or two stents. If it is two stents, which specific technique you're going to use. Finally, just a word about patient selection. Very often we think it's a quick and easy calculation, but I would encourage everybody to kind of remember these factors that we talked about first, but also that I think, in my estimation, every patient who goes for left main, unprotected left main PCI really needs a multidisciplinary review. And the more people you can have involved in this decision, the better. I think, perspectives from different surgeons and different interventionalists is very key. We kind of need to make sure we understand all the factors that apply, and so we understand and choose which revascularization strategy would be most beneficial for that particular patient. It's very often complex, and so I think it shouldn't be a one-person or two-person decision. So, how did we get there from 25% mortality to 1% mortality? Certainly, stent design has a lot to do with it. Remember, increased use of intravascular ultrasound. All of the literature in this area really had a less than 50% utilization of intravascular ultrasound. So whether you're looking at DK Crush or most recent EBC main study, it's really still in the minority, even though we know it has mortality benefit. So we want to make it 100% here at our institution. It's available, and lots of experience. The stenting techniques, I think, in my opinion, the DK Crush still has the upper hand if you're going to use an upfront two-stent strategy. If you identify somebody who has complex distal left main disease, I think the pharmacology really, these patients deserve either ticagrelor or Efient. I don't think that left main PCI should be Plavix because of the possibility of Plavix non-responsiveness. And discussion, unprotected left main angioplasty is standard treatment in 2022. I think we can, in the right circumstances, perform it safely with reasonable outcomes in the appropriately selected patients. I think that success is defined by careful planning. We should not do ad hoc left main PCI, routine intravascular imaging, appropriate patient selection and technique selection, and operator and institutional experience. So thank you guys for your attention, and gals, and I'm happy to take any questions.
That was a wonderful talk, Dr. Pfau. Any questions in the chat? Does anybody have any questions? I certainly have a couple that maybe I'll start off with while people are thinking. So, Dr. Pfau, in most of the left main interventions, at least that's my observation, that restenosis at the cergosteum seems to be, like one of the recurrent things that happens, or maybe in high proportion, I'll say, in terms of failure of the left main stenting. What are your thoughts about that, and anything that we need to do intraprocedurally, and why that happens?
Yeah, so I don't, you're right that that seems to be the most common mode of failure. But I think there are several things. First of all, the circumflex in general is the smallest artery, so it's going to have the smallest area when you're done. Secondly, I think there's often a very high plaque burden, relatively speaking, to the artery size there in the circumflex. But I think that's why careful imaging and expansion is key. I don't know that there's any other thing that we can do to guarantee better outcomes there than careful imaging. DK Crush, I think, at a 5.5% incidence of circumflex ostium restenosis. I think we'd all take that. So I do think that technique matters. And, I've been pretty outspoken about my belief in the DK crush technique. I don't understand why it's so much better, but I think the data speaks for itself. So I think careful IVUS and the right technique will minimize that.
And what are your thoughts about, there's a lot written about recently about the DK nano crush technique, and do you have any experience of that? Or I know a few cases were done at the VA.
Yeah, my only experience is watching Samit do it. So it seems a little exciting to me, but I think it's like everything else. It seems like a good idea, but it really needs to stand the test of time and good randomized data. And, I think the group in China who's kind of really pushed the DK crush technique has done a great job of a whole series of studies using that technique. And so I'm kind of waiting for the nano crush data in the left main to kind of make sure I understand it and make sure it makes sense. And just like DK crush 3 kind of answered the question of culotte very carefully, I think, nano crush needs to be compared to the best technique we have now for 2 stents, and that's DK crush. So I don't know if that trial is going to get done, but that's what I'd like to see.
And what do you think about ultra thin struts in the left main?
I'm in favor. I think that really the ultra thin struts have the best results. And I think if you get things dilated and appropriately modify the plaque in the left main with either atherectomy or shockwave, then I think strut thickness being as small as possible is only going to help you in terms of long-term outcomes. So there is data, emerging data, that shockwave can be done safely and with good outcomes in the distal left main. I didn't have any of that data to share today. And there's also some case series of the ultra thin strut stents that show very good results. So I'm in favor. I think the data is all moving that way.
Right. Does anybody have any more questions?
Steve, that was a great talk. Can you just spend a moment on, give us your perspective of when we do a provisional stenting from the left main to the LAD, when we should intervene on the circ ostium? Because, I think people often take their lessons from non-left main bifurcations, that as long as you have TIMI3 flow, you can leave it. Obviously, the circ is one of the 3 major epicardial coronaries. So do you have a view on having a lower threshold to intervene after provisional stenting?
Yeah, that's a great question. Unfortunately, there's not a lot of good data about that. I agree that you can't really extrapolate non-left main bifurcation data to the circ in left main. So the only time I think you should leave it is when it really looks perfect. When it looks exactly like when you started, there's not much disease there. And then I think it's safe to leave it. If you've made it worse by your left main stenting, I think, a 50% or a 60% angiographic stenosis is not something I would like to leave behind. But that's not based on any data. I haven't really come across any sensible or kind of systematic review of what criteria we should use for that. But that's my personal take.
Is there any role of FFR in these situations?
Well, I think that's extrapolating from non-left main bifurcations. And so, no, I think that, I would be hesitant to use FFR as a discriminator about whether to leave the circ or not. I think, the angiogram and IVUS after your procedure are are going to be key. And so until we see some data that that's a good discriminator, I think the angiogram should really be what we use. I don't know. What do you think, Yusuf?
I agree completely because, I think I've seen a couple of cases in my training where it's been left or had other cases, and these can have catastrophic outcomes because you can then have an issue with closure in the circ, and then the left main stent goes down, and I just, we shouldn't, I think exactly what you think, we shouldn't leave it if there's just TIMI-3 flow. If it looks in any way altered, and then at the very least Iversid, and then some form of intervention, ballooning, and then decide if you need a stent.
Yeah, exactly. The stakes are high, much more than any other bifurcation. So I think we have to be really conservative until there's data to guide us in a different direction. And by conservative, I mean kind of get our absolute best results angiographically and by imaging.
Steve, you also have one more question, a view on how far back to extend the left main stent when the ostium is not necessarily diseased. Do you favor covering the ostium in more or less all cases?
No, I let IVUS guide me, so I think if you have a segment of the left main proximally that is not diseased or is minimally diseased, then I stay away from the stent. I just want to have enough stent so that I can get a good 10 or 12 millimeters of stent in the left main, so I can use an 8 millimeter balloon for pot and make sure that the stent gets expanded. So no, I don't think you need to go to the ostium in every case.
One more question, Dr. Pfau. Tips or tricks when the angle, especially of the circumflex, is in such a way that, when you try to IVUS, the IVUS jump and you can't really get a nice, run. Do you do more balloon dilatation? I mean, how would you approach that if you're imaging or you switch to a different modality?
Yeah, so Carsten, I really am not in favor of the eagle eye, and that's the problem with the eagle eye, is that it's kind of bulky and you're doing it manually. And if you're trying to go past the stenosis, very often it sticks at the stenosis and then jumps past. And so you really need to use either the Refinity catheter, where it kind of moves smoothly through a microcatheter so the IVUS itself doesn't touch the lesion, or OCT, which works the same way. You've kind of got a microcatheter through the lesion, and then the imaging part of the catheter can move without any restriction by the plaque. The eagle eye, in my estimation, is very difficult to use for pre-stent imaging for that exact reason. And so I would just say stay away from the eagle eye.
Eagle eye.
Yeah.
Thank you.
Steve, do you handle antiplatelet therapy differently with the left main?
That's a good question. I don't believe in Plavix, as I said. I think the stakes are just too high to take that chance. The question of how long to treat with antiplatelets after left main PCI is, the data is all over the map. So for example, the Onyx study, 30-day study, which I'm blanking on the name of it, had about a handful, 45 or 50 patients who had left main PCI and had their antiplatelet therapy stopped after 30 days, which to me seems pretty exciting, to say the least. But I do think if you get a good result, it really is the biggest part of the artery, and the flows through the left main are so high that it should be okay to stop antiplatelet therapy, just like you'd stop it for any other lesion. So I don't think, that you need to think of it differently just because it's the left main. The consequences are different, But our stent thrombosis rates are so low these days. And if you get a good result, and if you use IVUS guidance, and if the patients take their medications, I think you can still use the same guidance. I don't think it matters in terms of aspirin. You know, you've all heard me say that I think aspirin is kind of really unnecessary. And I would say that the same is true in left main angioplasty, especially on those patients who are on anticoagulation for AFib. I really frown on triple therapy, and left main should be no different. But the absolute duration, I think you should use the same guidelines as you use for other patients who get angioplasty. And Rob put in there, it's the Onyx 1 trial. Thank you, Rob. Yeah, Onyx 1 had a handful of patients with left main stents, and they were stopped after 30 days. So I don't have anything special. Long answer to a short question. All right. Thanks, everybody. Thank you, Karthik.
Thank you. That was an excellent lecture and a great conversation at the end. Until next time, thank you
All right.
guys.
Take care.